as an anti-craving agent in addiction, we only have few molecules. Among them, Acamprosate is one of the important molecule. So this will be the educational objectives. What is Acamprosate and how does it act, and indication in alcohol use disorder, and its efficacy and effectiveness, that is evidence-based till now. Now, if we see the drug development, almost for 5 decades after disulfiram got FDA approval for use in alcohol dependence, there was no drug. Then naltrexone got approval for treatment in alcohol dependence, and then after another 1 decade in 2004, Acamprosate got the FDA approval. So if we see as a chemical compound, it's nothing but calcium acetyl homotorinate. So structural analog of amino acid taurine. Taurine is one of the principal amino acid of CNS, which is inhibitory in type, and Acamprosate represent a prototype of neuromodulatory approach in treatment of alcohol dependence, that we can say. Now, how does it work? Truth to be told, the exact mechanism of action is still uncertain, but as we know how alcohol works, the neuroadaptive adaptation in the CNS, like just after few drinks, excitatory neurotransmitter, which is glutamate, is been decreased, and inhibitory neurotransmitter, that is GABA, increased. That's why we know that alcohol is a depressant, CNS depressant. But when it becomes chronic, then body always like to be in a balance. So body try to make a balance by upregulating the GABA receptors and downregulating the upregulating the glutamate receptor and downregulating the GABA receptors. So a chronic alcoholic state is hyperglutaminergic state. So whenever the patient stopped taking alcohol, abstinence, or try to abstain from alcohol, the balance shift towards glutamate. So there are withdrawal symptoms and other complications of alcohol withdrawal. So Acamprosate play an important role in this aspect. As we have already discussed, it has a neuromodulatory effect, especially in NMDA kind of any type of glutamatergic receptor, and at the same time it increases the inhibitory GABAergic action is also there. So it again re-establishes the homeostasis or the normal balance of our body. So if we see the pharmacokinetics, one very important thing to remember is that the enteric coated capsule helps to increase the elimination half-life. If we give this as a without enteric coated, the half-life will be around 3 hours, but it become almost 10 times if we use enteric coated capsule. And steady state concentration usually reached around 5 to 7 days, and a moderate distribution of volume, that is around 12 liters. And during repeated oral admission is important to achieve the steady state. And that is one of the drawback also of Acamprosate, because it has to be given 3 times a day. And but there are some very important advantage of Acamprosate. It is not protein bound, and it is not metabolized by any enzyme in the liver. So most of the Acamprosate are eliminated by kidney through unchanged form, and others are secreted in bile. So as we have already discussed, that there is no enzyme involved in metabolism, so very minimal drug-to-drug interaction, and concomitant administration with naltrexone may increase plasma level of acamprosate, and it's actually beneficial without causing any side effect. It tends to increase the efficacy of acamprosate. Now, how to prescribe? It is available in 333 milligram in tablet form for adult weighing more than 60 kg. The recommended dose is 1998 milligram. So better to remember as 2 tablets thrice daily. And for adults weighing less than 60 milligram, it's 1332 milligram. So better to remember as 330 milligram 211 per day. So it should begin just as soon as possible, just after the abstinence. Even during the detoxification phase, we can give, and it should be continued for 1 year. And if patient again go back to the earlier drinking pattern, it can be continued for 4 to 6 weeks. Then if the situation that doesn't change, then we can stop it. Now, for initiation and for tapering, both of these cases, no need to titrate the dose. We can start with the highest dose and we can stop without any tapering. Now, side effect, it's vastly very safe drug with minimal side effect. The main side effect being diarrhea. GI upset is the main side effect. Reason being, as we have already discussed, that it is an amino acid derivative, so osmotic absorption of GI tract increases, hence the side effect. And in meta-analysis, it shows that 16% patient suffered from diarrhea versus 10% in placebo. Other complication being abdominal pain, nausea, vomiting, pruritus, anxiety, depression, though have been seen, but it's not that common. And in contraindication, severe renal and hepatic impairment is the only contraindication, and also should be avoided in individuals with pregnancy and breastfeeding, especially in the first trimester of pregnancy, because data is not available. So if we see in the special population, mild renal impairment, that is if the creatinine clearance is more than 50, acamprosate should be given in the same dose as others. But for moderate impairment, recommended dose is 330 milligram thrice 3 times daily. And as we have discussed, that severe impairment, it should be avoided. So in hepatic impairment, dose adjustment does not required because it's mainly excreted by renal clearance. And in elderly, some patient may tolerate lower dose better because of baseline renal impairment in elderly population. Pregnancy, it's categorized under category C, and then we'll move on to studies that have been done on acamprosate. So we'll start with Cochrane review. This conclusion of Cochrane review is based on 24 RCTs with more than almost 7,000 participants. And compared to placebo, acamprosate was shown to significantly reduce the risk of any drinking, that is complete abstinence. And also number needed to treat is around 9. And significantly increase, also it significantly increases the cumulative abstinence duration. But the secondary outcomes, that is GGT, heavy drinking, those are not attending statistical significance, but it's improved. But contrary to that Cochrane review, now we'll discuss about the largest study in the field of anti-cravings and management of alcoholism is called a combined study, randomized control study. 1,383 alcohol abstinent volunteers were included, and they were divided into 9 groups. 8 among them were the drug-related groups, and in this study, they have evaluated for up to 1 year after treatment, but the treatment period was for 4 months, that is 16 weeks. So 2 primary drinking outcome were there. One is percent days abstinence and time to first heavy drinking day. So the result shows that though all group substantially reduced in their drinking pattern, but patient received medical management with naltrexone and CBT having the better outcome compared to others, while Acamprosate showed no significant effect on drinking versus placebo, either by itself or with the combination of other modalities of treatment. So it's a negative study. So after the study, they again evaluate what could be the cause of this negative study, because Acamprosate yield good result, at least moderate effect size in most of the RCTs earlier done, and also it has good effect in animal model also. So they have evaluated the moderating factors in combined study and which are the subgroups that can be benefited from Acamprosate. Then they saw that the shorter abstinence period and the body mass index, these are the 2 factors that tells us that the Acamprosate will be useful in this population. So we can hypothesize from that that as we know that from the mechanism of action, Acamprosate acts like artificial alcohol. So while the patient is already taking drinks, it will not work properly. So minimum period of abstinence is required, and along with it, as we have already discussed, moderate volume of distribution in increased body mass index, the drug is distributed, so it's not reaching the appropriate level in the blood. So that would be an important factor. So in these 2 factors we should remember before prescribing Acamprosate to any patient. Now, this is another meta-analysis which compared naltrexone and Acamprosate, and it tells us that Acamprosate had a significant large effect size than naltrexone on maintenance of abstinence, whereas naltrexone had a larger effect size than Acamprosate on reduction on heavy drinking and craving. Now we'll move on to another large study, that is PREDICT study. Combined study was done in USA, whereas PREDICT study was done in Germany, and it was mainly based on the model of combined study only, and it incorporated 426 alcohol dependent patient. It divides into 3 groups: Acamprosate, naltrexone, placebo. It followed up for 3 months, and in this study also neither Acamprosate nor naltrexone have any benefit compared to placebo. So it is also again a setback for these anti-craving agents. Now we'll move on to some of the very sophisticated studies. This study was published in Nature. It actually evaluated what are the factors that can predict the good response with the treatment of Acamprosate. As you can see that the significant result are, one is the gender. The male are seems to have good response with Acamprosate, along with another factor, baseline PAC score, that is Pennsylvania Alcohol Craving Scale score. The patients who are having less score, that is less craving, are seems to have good response with Acamprosate. Along with that, they also evaluated 35 metabolites, among them 6 metabolites with increased base level of 6 metabolites. They found a good response with Acamprosate, like glutamate, ammonia. Now, some of the pharmacogenomic studies were also done on Acamprosate. like some of the polymorphism, like GABA A receptor subunit polymorphism and transcription factor of ANP, and also NMDA glutamate receptor subunit gene polymorphism found to have good response, but it should be repeated. Now, this is the latest meta-analysis on Acamprosate, which is published on 2015. 22 RCTs with 2,649 patients. It also shows a significant lower risk of lapse with Acamprosate, and no increase in adverse effect, so that patient discontinued treatment. So even compared to placebo, there is no significant discontinuation rate, especially in European population. They are saying that Acamprosate actually increased the treatment continuation rate. So we can summarize that Acamprosate works as a neuromodulator and normalize NMDA glutamatergic hyperexcitability, relatively safe with fewer drug interactions. Number needed to treat around 9, although randomized control trial suggests moderate effect size, but large studies comparing with naltrexone and placebo did not show any significant difference. Thank you.